Welcome to Science with Soul. I'm Dr. Lottie Valentine and the host of this podcast. I'm a physician, evidential psychic medium, international keynote speaker, and author of Med School After Menopause, The Journey of My Soul, an inspirational story about transformation, healing, and spirituality, available online at Amazon as well as other online platforms worldwide. The inspiration for this podcast came from my own life experiences. As I have journeyed through life, it has taught me that we're part of a greater divine web of interconnectedness. I have walked the path of illness, healing, and transformation. After two near-death experiences, I became clairvoyant, clairaudient, and clairsentient, and was guided to attend medical school at the age of 54. We will be meeting with many different types of doctors, healers, as well as spiritual leaders, educators, and other inspiring souls in this podcast. It is my hope that you will gain information and create a path to healing your own life, physically, emotionally, and spiritually, and bridge the gap between science and soul. If you are a person who understands the interconnectedness of mind, body, and soul, and would like to take one of my courses or work with me to create a path of healing your own life, please visit divinespiritualessence.com or drlottie.com. Welcome to Dr. Lottie's Science with Soul. Today, I'm delighted to introduce Dr. Rebecca Patton. Dr. Rebecca Patton has a doctorate in physical therapy from Duquesne University and also has extensive training through the Herman Wallace Pelvic Rehabilitation Institute. And she is the founder and owner of Patton Pelvic Health. Her vision for Patton Pelvic Health was created out of a necessity to provide more individualized and personal care to those who are experiencing pelvic health concerns. She was frustrated with a rushed and protocol-based healthcare system that was not prioritizing individuals. She wanted to create a space to empower patients to be included in their medical care. She is humbled that patients trust her with providing care regarding personal and often stigmatized issues. She specializes in treating all genders who have been experiencing pelvic pain, bowel, or bladder concerns. Her goal is to minimize additional trauma that can occur from navigating a complex medical system and create a personalized care plan together with her patients. Her passion is to destigmatize pelvic health across the gender and sexual identity spectrum. Everyone should have a chance to feel secure in managing their bowel and bladder health and have pain-free sex. She knows the burden that people carry when they're dealing with pelvic health concerns. She wants to give you back your power and help you feel confident in your body. So welcome, Dr. Rebecca Patton. I'm so excited to have you on the show today.
Thank you. I am so happy to be here, and thank you for asking me to come on your show.
I can't wait to have you share your knowledge. It's not a topic that we usually discuss, pelvic health. So, what is the difference between pelvic physical therapy compared to regular orthopedic physical therapy that many people have gone to physical therapy for maybe a back problem or they broke their leg or something like that? So, what is different about the pelvic physical therapy?
For sure. So, a lot of pelvic physical therapists look at the bowel and the bladder habits of the patient in that very first session, which is really important. And we also are asking sexual health questions. And so those stand out to be a little bit different than the typical physical therapy. We also do internal pelvic floor retraining, which is the pelvic floor muscles that control bowel and bladder habits and also dictate a lot of how we engage in sexual activities. And then in addition, we look at the visceral or the organ movement, and we look at surgical histories that have occurred through the abdomen, which is not common for an orthopedic physical therapist to do, although they can get specialized training within that as well. So we talk about everything personal And it's usually a more private setting for that to happen. So it's usually, instead of it being behind a curtain or in an open gym room, we are usually behind closed doors for all of that pelvic health work.
Wow. And what led you to this specialty?
Um, Mostly out of curiosity at first. In school, I wanted to take a clinical once I heard about it, and secretly, a little bit of my own pelvic health issues that I had curiosities about, but I didn't have the confidence actually saying those out loud. So in school, it really manifested into, man, I just want to take this clinical and see what that looks like first. And it was almost an instantaneous hook, um, because it felt so different. The connection with patients felt stronger. Um, I felt like I was using more clinical skills. It was really a whole different world that I wasn't prepared for in school at all. So I realized I had a lot of extra work to do. I realized that school was not going to teach me how to be a pelvic health physical therapist. So I had to take a few years to really learn before I actually specialized in pelvic health. And I appreciate um, the vulnerability that patients share, because I know they don't have to. They don't have, when they come into your office, they oftentimes, like, if you're not asking the question, they're not sharing that information. And I realized from my own healthcare that there was a lack of comfortability asking certain questions, sexual health questions, sexual identity questions. What does sex look like for you? Are you in a heterosexual relationship? Are you in a different type of relationship? And I think all these questions are really important to be asking our patients, because if you're not asking them, then who is?
No, that is so true. And I think many people would be reluctant to bring it up. I think it's, such a private issue for many people. So when they come to you, you help them by asking them different types of questions so that you can really learn about them.
Yeah, I think it's super important to practice trauma-informed care, which is really getting the history of an individual and understanding what got them to this point, because most people don't find me as like the first level of provider of their pelvic pain. Usually I'm like the fifth or sixth doctor that they've been to. And that comes with a lot of healthcare burden, a lot of repeating your story, um, a lot of being gaslit by previous doctors, so a mistrust of healthcare providers in general. So by the time they come to me, I'm already with the assumption that they've been through some stuff. They've been through some stuff, and they haven't been asked the right questions to get the right care. So I got to really have a lot of time to navigate what they have gone through. And that's going to play a big role in how I treat them as well.
And so the patients that come to you, what are some reasons that someone will seek out pelvic physical therapy?
Mm-hmm. So, a general term that people say is pelvic pain. And pelvic pain is really any pain below possibly the umbilicus, your belly button. It could be tailbone pain. It can be hip pain in the front or the back. It can be the pubic area. It can be the genitals. It can be the perineal area between like the vaginal opening and the rectal opening. It could be rectal pain. It could be urinary incontinence, which is leaking. It could be constipation, having trouble going to the bathroom. And it could be abdominal pain from surgeries or endometriosis and other hormonal conditions. You could have some people complain about pain with sex. That could be external pain or it could be internal pain. It could be tailbone pain, I think I mentioned everything. And then unresolved back pain. A lot of people will get to orthopedic physical therapy with back pain, but then they try 6 to 10 weeks of it and it doesn't get better. Sometimes I get referrals from other orthopedic physical therapists like, hey, I think something else is going on. That's kind of referring from their back pain. Can you take a look at that? So there's a wide variety of things that are happening, but I'm still looking at the whole body. So I'm still a physical therapist that's looking at the shoulders. I look at the neck. I look at the rib cage. I look all the way down to the feet. I was looking at somebody's arches today that related to their pelvic floor pain. So it really is full body, but there's just an extra component with bowel and bladder habits and sexual function.
Wow, that is so fascinating, especially when you talk about the tailbone, for example, and somebody who might have been in physical therapy for back pain and things aren't really getting that much better and they're doing everything, and to find that connection that is really originating from another area. What is the most common things would you say that people come to you for? What do you see
I,
a lot of or more of?
I see mostly pain with sex, penetrative sex for cisgender women. That would be the most common thing I see. And then tailbone pain would be the other one. People fall on their tailbones. People people hurt their tailbones in so many ways. And the tailbone is right, it's the end of that dural tension in the body. So, that tailbone pain can present in a lot of different ways, all the way up to people having headaches. And if we're treating the whole spine, we're really thinking about all of those fascial and dural connections, there's a lot of reasons to be looking at the tailbone. And then how that tailbone relates to the pelvic floor. So whenever you tense up your pelvic floor muscles, your tailbone is going to bend and flex more. And whenever your pelvic floor muscles are relaxed and they have a lot of mobility, it's going to allow your tailbone to move better.
That's so interesting because people, might not be thinking about that. And oh yeah, I did fall on my tailbone 2 years ago, and then they, it stopped hurting. The bruise went away, but now they have these other problems that are related to the tailbone, but they have forgotten that they, fell off the ladder or slipped on the kitchen
Absolutely.
floor or something, right? And then they have all these other problems. What do you see? What happens to people? You mentioned, sometimes people have surgery, for example. So what can happen after people have surgery, like scar tissue or things like that? Does that then cause problems later on?
Yeah, let's talk about just, for example, like a C-section scar. Um, it could impact all of the abdominal muscles. It can impact any of the lumbar plexus nerves, that like your ilioinguinal nerve, genitofemoral nerve, iliohypogastric nerve. Those three nerves can that go through the inguinal canal. That definitely can impact clitoral pain, pain in the mons pubis, pain in the upper labia. And a lot of people who have had a C-section are like, why does my labia hurt? And I think painting a picture and giving them a connection to why these things are happening. I mean, it should just be a standard of care to send someone after they've had the birth of a child to physical therapy, because you wouldn't cut through someone's shoulder and not send them for post-op rehabilitation. And if one visit at 6 weeks is not enough to help that person feel better. Some other things that we see surgically obviously would be after endometriosis surgery, an excision of endometriosis, they have a laparoscopic surgery. So they just usually have 4 little incisions, or maybe one through the umbilicus or the belly button. But that is adhesions that have been in their body for probably years. And if we know anything about the treatment of endo, it's probably been there for a decade by the time they're actually getting surgery. And so we want to work on retraining the body to move again without those adhesions there. And we want to prevent the buildup and the scar tissue of other adhesions happening. So we really want to work on the fascia to move better. And that fascia is like one big, multiple layers of sheets that should be gliding past each other. And if they get stuck, that's going to affect the nerve from moving. It's going to affect the blood flow. It's going to affect the lymphatic drainage. And that is a reason to come into physical therapy or see a pelvic health specialist, because I think of us as not just pelvic health specialists, but also specialists of the abdomen, of abdominal surgeries. And that's a whole other ball game when you're talking about all the visceral organs and the connections within the body, how the rectum is right in front of the tailbone and the sacral plexus nerves, where the uterus is sitting, how the uterus is positioned, where is the bladder moving? Do people feel like they can hold their bladder? Is their bladder able to expand? Are they able to wait to go to the bathroom? And that requires a lot of mobility from the fascia in the visceral organs. And if they can't move, then probably someone's going to have a pulling sensation. They're going to have referred pain. And it's a little bit intimidating. It's more intimidating to have pain in your pelvis than it is to have, pain in your knee. We know there's not, there's a little bit different of how a patient is receiving that. And so they tend to be more guarded and protective of that. And then in turn, what happens too is like the breathing changes. So they stop using their diaphragm to breathe, and they start protecting and guarding their thoracic area and their abdomen. And that really has an effect on how you move through your day.
Wow, the whole body gets involved in, that one that one surgery that person had. And I think we tend to forget, our medical system is so honed in on this, you have surgery, now you're fine. And we forget about the second part of healing that has to take place, regardless of the surgery involved. The people, for example, you mentioned people have a hard time, for example, holding their urine or their bladder. And this is also a common problem when women are aging, that they have like leaky urine, or they're not able to hold it. And I've had many patients myself, and I always send them to physical therapy. How can these people be helped? Like what does that look like? If somebody is listening now saying, oh yeah, I have this problem, but I'm afraid of bringing it up, or I feel, ashamed about it. When they come to you, what happens next? What is it that they do to help that problem?
Gotcha. It's the first is I have a pretty in-depth questionnaire. I would say more in-depth than most practitioners about bladder and bowel habits. So I want to know, do they feel like they can hold it? Do they feel like they can empty all the way? How long can they hold it for? How much water are they drinking? What else are they drinking besides water? So it's just really getting a detailed. And then I want to hear in their words when they come in also what that looks like for them, because it's different writing it on paper, but then I want to hear their interpretation of things, because there is a lot of I don't want to be trying to fix something that the patient does not want fixed. Does that make sense? Like,
Yeah.
I've got a list of things that I want to work on in my mind, but if they feel that something else is a higher priority, that might be on the back burner for me in terms of functional goals. So I really prioritize it based on how, when they're verbalizing it to me, how impactful is this in their life? And if I think it's a really high priority and they maybe don't see the connection, I'm gonna mention why I feel like it might be related to pelvic floor dysfunction or past surgical interventions or things like that. And so it's a lot of talking for the first visit and really trying to figure out their history. But ultimately, usually we decide that a pelvic floor exam and internal assessment is most appropriate next, once I kind of have a picture of what their bladder habits look like. And so we do an internal exam. And so what that kind of looks like is it's not a gynecological exam. So I don't use a tool. I don't use a speculum. I have a single gloved finger and I insert finger vaginally and I press on their pelvic floor muscles. And that's done with a whole lot of education about the anatomy beforehand. And it's also done with consent. And it's a more present exam, as in the patient's going to be actively trying to feel something, whereas a pap smear I consider very passive. So they're just kind of going along for the ride and hoping that they don't have too much pain, right?
Yeah.
But in this scenario, I'm asking them to use their muscles, and I want to know, can they feel that muscle being used? So I press around the urethra. I'm going to press around the levator muscle, which is like the hammock muscle of the pelvic floor. And I want to know how much strength that muscle has. I want to know, can that muscle relax? And can they push it down to stretch the muscle? And the common misconception about urinary incontinence or leaking is that it's all about Kegels, right? It's all about
That's
just tensing up your
exactly.
pelvic floor.
Yeah.
And if that fixed everything, let me tell you, I wouldn't have patients because everyone would just be at home doing their Kegels all day. But it really doesn't. It really doesn't fix everything because it's so much more than just contracting and relaxing a muscle. That muscle needs to have coordination, and it needs to have timely coordination, and it can't be contracting all day. And some people work on so much on the contraction they forget that it's also a muscle that needs to have a range of motion. So that muscle needs to be able to drop and expand, like when you're squatting or going to bend over to pick something up, or when you're going to the bathroom and having a bowel movement. And if that muscle can't do those things, then they're going to have trouble. And actually, I see hypertonic or over contraction of people's pelvic floor muscles is often a contributor to their leaking. And so we actually have to get the muscle to learn to relax before we train it to do anything else. And that's even in the case of leaking too.
That's really interesting. Um, so does that mean that they have done too many Kegels? Or
People could definitely be doing too many Kegels for sure.
I
Yeah.
mean, that's
Or
the one thing they tell you, right? That having given birth to three children, now you do your Kegels for, a couple of months to make sure everything goes back to normal.
yeah, and also the pelvic floor does not function by itself. It functions with the diaphragm, with the breathing system, with the rib cage. And if you didn't know already, like your body is just one big pressure system. You're constantly managing pressure with your nasal cavity, you're managing pressure with your epiglottis, you're managing pressure with your diaphragm, you're managing pressure with your pelvic floor. And you can't just retrain the pelvic floor by itself. It just doesn't do that. It retrains with the diaphragm, its counterpart, and those things need to be moving well together. So a lot of people, they're doing Kegels and they hold their breath, or they're doing Kegels, but they're bearing down at the same time as they're trying to lift their pelvic floor up. It's like putting a weight on top of your pelvic floor as you're trying to strengthen it. And so there's just so much lack of general information about how our pelvic floor actually functions that we think that we can just tense and relax a muscle 200 times in a day and that'll be like our exercise. Or we buy those like vaginal weights or things like that, and we just hold them in there and walk around with those in. That's not how I would functionally say that I would use the pelvic floor either.
And for people, I know when people age, for example, and they get, up in age, let's say, 70s, 80s, even 90s, the typical thing you hear working as a physician is, I ask them, how much water do you drink? Well, I don't like to drink water because I just have to go to the bathroom all the time, right? And I know in my own mother, and she would say, oh, I get so dizzy and lightheaded. And I would tell her, Mom, you have to drink at least 8 glasses of water. And the concern was always the same, right? Then I have to go to the bathroom too much. So these people, this is a common problem with people that are aging. Can you help these people?
Yeah, because avoiding water is not going to help you leak less. And I promise you that. I'm going to say that again because I think it's so important. Avoiding drinking water is not going to help you pee your pants less. And there's so many reasons why this happens. But first of all, your bladder is an organ that remembers things. It knows. And so it knows your day, it knows your habits, it knows your lifestyle. And unfortunately, we can get into some bad bladder habits. That the good news is that they're pretty retrainable. They're pretty easy to retrain once you start to notice what you've been doing in your day. So, for example, the bladder can be receptive to water that is running, or if you usually go pee as soon as you like get in the front door, maybe your bladder is signaled by the garage door opening or you getting closer to your house. Or sometimes we, you know, eat and then go to the bathroom. Like there's so many reasons why our bladder gets into the habits, and it usually looks like what our day looks like. Or during COVID, a lot of people started working from home, right? And so they had accessibility to the bathroom, so they didn't have to wait anymore. So they just went to the bathroom a whole bunch, and your bladder remembers those things. And so sometimes it gets overactive in its signal that it's sending. It's telling you that you need to go before your bladder is actually full. And then when you avoid drinking water at the same time, your urine's going to be really concentrated. And with that really concentrated urine, that doesn't necessarily make your bladder any less likely to contract. It's just going to be more sensitive. So there's a lot that plays in with that, but the training of your bladder is separate and integrated, but not the same as training your pelvic floor muscle. And so the bladder retraining is habit and behavior, training how much water you're drinking, increasing that water capacity and letting your bladder hold that fluid and not rushing to the bathroom right away. And then your pelvic floor learns how to interact with the bladder instead of fighting it so much. So definitely we work on both things and we hope that they intertwine together. But the bladder is an autonomic muscle, so you can't really tell your bladder when to contract and when to relax. You just kind of have to retrain it with just simple strategies that hopefully give you more control. But I would say that 100% leaking and not drinking water go hand in hand, and not drinking water is usually not the answer.
Right.
Yeah.
Do you ever, you mentioned overactive bladder, and I know sometimes kids get a diagnosis of having an overactive bladder, and it's causing them also to have bedwetting. And it's, and they can be older children, 10, 11, 12 years old. Do you ever work with children, or is that another type of physical therapist that would work with kids?
Yeah, I do work with children, and it's a weird realm in physical therapy because there's pediatric physical therapy, right? But they don't have the training in pelvic health necessarily. And then there's pelvic health physical therapy, but we don't necessarily have the training in pediatric care. So I've recently started delving more into treating adolescents and treating children. And as long as I have the time and the parent is there, it works out pretty well in terms of strategies. But most pelvic floor dysfunction happens, and I think it comes from when we're children. I think it comes from not knowing how to listen to our bowel and bladder from when we're at a young age, and constipation becomes a normal part of our life, or bedwetting kind of becomes a normal part of life, and we just symptom management, but we don't really like fix that problem. So certainly pelvic health physical therapy can treat pediatric incontinence. For you just have to find the right person, because not every pelvic health therapist treats children. That's all.
Mhm. And what about men who, let's say, they're having a large prostate, and they wake up every 2 hours all night long to go pee? Um, do you ever work with men with conditions like that?
Yeah, I work with them. Unfortunately, I would say that the standard is that they have their prostate removed first and then they get referred to pelvic PT, but I would love it if they got referred before that.
Right.
And I think that would be really important, because I think it would be easier to retrain their pelvic floor muscles before they've had surgery, and retrain their bladder a little bit and address structural adhesions within the pelvic floor before they have surgery, to see how that improves their symptoms. And I think it's a whole other ball game training their pelvic floor muscles when they're leaking all the time after surgery. And I think that becomes a little bit harder to get somebody where it's not impossible, but
Mhm.
the standard right now is that they just get referred maybe 6 weeks to 3 months after they've had their prostate removed. But I certainly would like to see the direction of care go towards having pelvic rehab before they have their prostate removed.
You were also mentioning that one of the common problems that you see are people that are having issues with penetrative type of sex. What kind of different kinds of problems causes that for people?
Mm-hmm. This is what's so important about getting the medical history for somebody. And a small portion of people is that it was sexual trauma from when they were younger or recent sexual trauma, and their body has now protected against that response. But it could be from a childbirth, a traumatic childbirth, and their body had experienced just a tear in those tissues, and they just waited for that to heal. But their muscles in the meantime tensed up in response, and they didn't learn how to relax again after they had their baby. So I see that very often. And I think that a misconception is that, oh, if you had a baby, sex is going to hurt a little bit at first, no matter what. And so I think a lot of people sit and wait with that for a while before they actually do anything about it. But there's so many things happening at that time that I think you just need people there for you, because you're breastfeeding, that's affecting your tissue hydration and your lubrication, and that's affecting your libido. And so all these other extra things are also going into care. And I think we need to see the full person and their experience along with that, because a lot of times it's going to be multifactorial. Like, yes, you have pelvic floor tension, but also you probably need some estrogen, or you need some hormone management from your physician, or you need some naturopathic care. And so I think those are important things to be addressing at the same time. Some other causes could be, again, tailbone tailbone pain. I see it all the time. People fall on their tailbone, and their tailbone no longer hurts directly to sit on, but their muscles have now tensed up. And so pain with penetration and tailbone pain I see all the time. And then I'm trying to think of some other reasons why pelvic floor muscles would hurt with penetration, but
What about the position of somebody's uterus? Could that affect it, or endometriosis, or?
Yeah, for sure, 100%. Endometriosis, not usually very comfortable, and it'll look different too. So depending on a typical pelvic floor dysfunction, that could be very superficial in terms of their pain. They're like, it's right there at the opening. It feels like as soon as something's being inserted, I have pain. Endo pain really can look different than that. It could be pelvic floor as well, but additionally, they'll kind of say things like, it feels like my uterus hurts, or it feels like something is in the way or obstructing, or it feels like, if they get GI pain from that, which I see really commonly, or they feel like they have to pee. And it's just all these adhesions and all these nerves talking to each other. And so especially if it's before they've had endometriosis removed, that gets to be complicated, because pelvic floor work is only going to go so far to treat that pain with sex. And so we got to look at the totality of how their pain is being managed. So that's a more multidisciplinary care team that needs to be together and on the same page with that patient. Mm-hmm. And then adenomyosis is a different story too. And then fertility kind of going along with all those things. And then we're thinking about PCOS as well, that can cause pelvic pain. So I think about IUDs, I think about anything that could possibly be in their reproductive organs, but all of those conditions look very multidisciplinary, as in I'm helping them with their pelvic floor muscles, I may be helping with the fascial tissue and the connections and the nerve pain, but I definitely need a doctor helping the patient manage hormone regulation and that cyclical pain that can come along with all of that stuff.
Wow, it's just fascinating how much can be treated with pelvic physical therapy. I hope everybody that listens wakes up and hears how much can be helped with all these different symptoms. What type of doctors refer to you?
Mm-hmm. Most typically, just a typical gynecologist. and an OB, a midwife, a doula, those types of like postpartum care clinicians will refer to me. Um, on a broader scale, a urogynecologist or a urologist would be really common, a naturopathic doctor, a colorectal doctor, an endometriosis specialist. I even have vulvar pain specialist doctors that refer. And if we're getting into the cancer realm, I have oncologists that refer to me. And then in the pelvic pain with trauma realm, sometimes a psychologist may refer to me. And then sometimes I get general surgeons that do like hernia surgeries or tummy tucks, and that has affected the nerves. So that's another common one too.
Yeah, it's a lot of different modalities and doctors that refer to you that need that pelvic physical therapy. So, what led you to establish your own practice?
Mm, so many things. Um, I wanted more time. I wanted more time with people. I was in a situation where I only had about 20 to 25 minutes with the patient. And I was realizing that if I really wanted to give the care that I envisioned people getting, I just had to step away to create that space myself because it wasn't there for me. And I also realized that a lot of pelvic therapists in my area really are doing a great job about prioritizing care for postpartum individuals and pregnancy, but there is a whole other realm of people that we're missing if we're only thinking about the pelvis for reproduction. And we're missing care for people that are not menstruating. We're missing care for people that have gone past that are menopausal, postmenopausal. We're missing care for trans and non-binary patients. So we have to. I thought it was really important to include everybody, and so I didn't want to make my practice specifically for postpartum or pregnancy. I still treat all of those things. I love treating all of those things. We absolutely need to treat all of those things, but we just use our pelvis for more than having babies.
Very true, and so important to include all different groups that need pelvic physical therapy, because a lot of people need it, and it hasn't even been suggested to them. So, when you work, what does trauma-informed care look like to you?
Mm-hmm. Like trauma informed care really looks like seeing the totality of the patient's experience, and not just their experience, but their interpretation of events that have happened and how they have internalized possibly some of that trauma. So, helping them feel in tune with their body again in such a way that is allowing them to have complete consent throughout treatment. And what that looks like is consenting now to a pelvic exam doesn't mean you consent to a pelvic exam on future sessions. It also does not mean that I assume that you're comfortable all the time having a pelvic exam on every single session. It also means that in the middle of session that you can revoke consent at any time. So consent is a really big portion of that. And it also kind of looks like little tweaks and changes, which is um, telling someone exactly what you're going to do before you're doing that. Because if people have disconnected or dissociated from their pelvis because of trauma or because of pain, then they can't feel necessarily what's going on. So you are pressing on things and they're like, I don't know, it hurts everywhere. um, that that trauma informed care to me looks like, hey, I'm going to move over here first. I'm going to tell you that I'm going to move, and then I'm going to move. Not, oh, I'm going to move without talking to you about it and then tell you afterwards, or I'm not going to insert digitally anything without telling you beforehand. So it's just like little tweaks and little nuances that we don't necessarily get when it's a really busy environment, when the doctor is super rushed. And although they try to do this, certainly, it just doesn't always come to play that it actually happens. And again, trauma informed experiences is like a let's say it's a birth experience that they felt was very traumatic. They felt like they weren't listened to through that labor process. Maybe they were laboring in a different position than they actually wanted to labor in. Um, Maybe they didn't get full information before a procedure was done and they didn't feel like they were informed about it. That person coming into me is going to have a very different um, response to me than someone who was like, I felt so empowered in my birth and my pregnancy, and my had my midwife there and they were super supportive, and I got to birth in whatever position I wanted and no one tried to push this on me if I didn't need it. And so I can see the person coming in and I can see what experiences they've had, and that is going to change how care looks a little bit.
That's fantastic. And just your awareness around that and each person being treated individually, personalized care that fits them. As we know, one glove does not fit all. And we kind of have developed a healthcare system that is such with the Western modern medicine. And Western modern medicine is very good at saving lives in the ER, but we're not so good at providing personalized care that is tailored to each individual person. And I love that what you're doing with that, and it's really providing personalized care for each person and how regardless of where they came from and who they are, it's for them. What is one thing you wish parents knew to help with their child's pelvic health?
Mm-hmm. I think constipation is a big one. I think if your child is having trouble pooping, that is a sign of pelvic floor dysfunction. That's a sign to not only be medically managing it, but it also could be a pelvic floor physical therapist. And then also, we talked a little bit about this before, but bedwetting is another big sign that they might benefit from some pelvic floor retraining. And for children, that does not look like internal pelvic exams. Oftentimes, like I said, the diaphragm is connected to the pelvic floor and their tummy is connected to their pelvic floor. So a lot of times I might like, if the child is comfortable enough, I might be looking at their tummy, and I might be looking at their breathing mechanics. I might be teaching them how to sit on the potty, how to breathe when they're sitting on the potty, how to be aware of some of their muscles in their pelvis, what that kind of feels like to go to the bathroom, and how they should be pushing. And I think that, and then just having some behavioral retraining. So, like when the parents should be trying to get them to go to the bathroom, when they should be saying, hey, let's try to wait to go to the bathroom, things like that. And then, nighttime, like alarm systems for getting them awake when they're bedwetting are helpful.
Mhm.
So there's a lot of strategies, but again, it's individual. And then the age is really important, because you're going to be treating someone who's 8 years old with bedwetting different than someone who's 13 who's bedwetting, and they're going to have different strategies. But overall, I think parents need to know that pelvic floor issues happen from a young age, and it might be appropriate to not only manage things medically with, medication and stool softeners, but also to maybe think about some other things that are happening in the body and teaching their bodies on how to relax and breathe.
Yeah, sounds very important. Such good advice. During the pandemic, physical therapists started being allowed to treat via telehealth. What do you feel telehealth has done for your patients?
Oh, I love being able to reach people that I never would have been able to reach or don't have access to gender inclusive care, right? If you have one or no pelvic physical therapist in your town, or you have to drive 2 hours to get to the closest one, what's to say that that person is going to have enough experience managing or telling you about the condition that you have? Because really, not all of us are trained the same, and so not everyone works with someone who has endometriosis. Not everyone implements trans and non-binary inclusive care. Not everyone certainly treats men, cisgender men. So if the only person that you have 2 hours away from you is someone that treats cis women, we're going to lose out on a lot of people having access to healthcare. So I like the fact that telehealth now, um, I can at least get them verbal care. You know, we can talk about how the pelvic floor functions, how it's moving, how it moves with the breathing. We can talk about bowel and bladder habits. And I like that people have access to that information. And sometimes they just need help navigating the healthcare system. Like they're like, who am I seeking out? Like, right? I talked about how many doctors refer to pelvic floor physical therapy. There's like 15. I don't know. There's like 15 different doctors that could possibly be referring to me. And so some people are just like, help me find a doctor. help me help me find this person who's near me. And I mean, at least I have the resources, and I'm in the community, so I know who to ask and who to be going to for those things. And I think that that's helpful for some people. And telehealth also allows people not to leave their house, which is the greatest part of it. So if you have a newborn baby that you're feeding every 4 hours, that is heavy to leave your house at the same time as that. So there might be some things that we can work on where you don't have to leave the house first. And then I can have you come into me later on in time, and or sometimes you're a caregiver or you're helping somebody else out. So it's really expanded care. It's not perfect for physical therapy in the sense that I don't get to put my hands on somebody. I definitely don't get to fully assess how their pelvic floor moves, but it is something. And I think that if people have access to it, maybe it gets them a step in the right direction faster.
Absolutely. And, there are many things that you can, like you said, like you can tell them and talk about it and create that awareness and change habits and lots of things. So it's a great thing that has come about from the pandemic, the accessibility for people to speak with somebody like you or other healthcare provider. So I know that you recently got vetted on eye care as a physical therapist. Now, I know that is a big deal to get vetted on eye care. It sort of moves you up. Like it shows that you have a lot of specialty in pelvic physical therapy because you have been vetted by eye care. So can you tell the audience what does that mean?
I mean, I recently found eye care better through a patient, and they told me about it. And I had been looking for a resource like this because before eye care better came along, the only real resource I had to refer my patients to might have been individual surgeons, or it was Nancy's Nook on Facebook. And so this kind of really expanded my comfort level with recommending surgeons, because I know that for their surgeons, they video vet them, which means that they're looking at their surgeries, and then I think they have to answer interview questions. And for physical therapists, we had to submit like a resume. We had to submit a patient experience. So a patient had to write out their experience being treated who was diagnosed with endometriosis. And then you have to answer some more questions about how your treatment style looks and what treatment surrounding endometriosis looks like. And then you answer I would say it was a tough quiz, a test. I don't know if it's a test, but it was, questions on a test, and it all is really good, up to date research questions. None of them are like super straightforward. They're all really complex, and trying to dictate what is best for that patient, and also the interdisciplinary care, what that looks like. Because, I'm not treating endometriosis, I'm treating the symptoms of endometriosis. And it's super important that I know my place within that scope, but also advocate for my patient to get the best care. And it's hard to find those resources for people. It takes so long, and it's one of the more frustrating parts of this practice and this work is definitely getting your patient who you suspect has endometriosis into a professional that sees it all the time and is going to take their pain seriously and not dismiss or gaslight them. And that, I mean, they've already probably been to countless doctors. So convincing somebody to go to another doctor is hard. It's not always easy, and they're always going to trust somebody new. So it's nice to have a resource like I Care Better to help us give people good information and say like, hey, we can trust this resource. It's certainly not out there. It's definitely something new, and it was very needed, and I can't wait to see it grow, because I know there's so many people that can be vetted on there.
Yeah, it's a great resource. And I'm so happy that you're on that list, because people, it's like you said, it's so difficult for patients to navigate the healthcare system and find the correct physical therapist and the correct doctor for their disease and problems. It's very difficult. I don't know how people do it, because you almost have to be a doctor or a physical therapist to navigate the system.
Yeah,
And yeah, it is so hard for patients. How in the world are they going to get to the right people and to the right doctor? And working in that field myself as a physician, you hear people that have seen, like you said, countless of doctors. So this is a great resource, and to be listed on there. So congratulations for getting on that list. It just shows that you really know what you're doing. How can people work with you? People that live in the Phoenix area in Arizona, that can come see you in person, or get to know you on your website. How can people find you?
yeah, you can use Google Maps, or you can look up my website. It's pattonpelvichealth.com. On there, I have a free consultation. So if you're like, I don't know if this is really for me, I don't know if you treat my condition, before you schedule a visit, I really encourage you to just fill out that form, and I'll contact you and we'll have a conversation first before I get you scheduled. Because as much as I want the right people coming to me, I want you to find the right person for you. And sometimes there are certain situations where I'm like, I have a better fit for you. And I'm really not, I'm not ego driven in that way that I need people to walk in my door all the time, every time I talk to them. I'm really more prioritizing what that person needs at that moment. And it might be me in the future, it might be me right now, but I certainly just want them to find a practitioner that works for them. So if you're in the Phoenix area, the benefit of even consulting with me is that I know people in the Phoenix area, and if I'm not the right person, I know exactly where to get you to. So my website, and then I also am on Instagram, and I run that Instagram myself. So if you message me on that social media site, then I am going to be the one that's messaging you back. Some people choose to interact with me that way. Some people choose to interact with me on my website, but either way, I'm fine with.
And how do they find you on Instagram?
Oh, yes. It is on my website too, on the bottom of the homepage, but it's at Rebecca Patton, REBECCA PATTON _D as in doctor, P as in physical, and then T as in therapist. So _DPT.
That's great. So everybody that is listening that wants to work with Rebecca, go to her website, pattonpelvichealth.com. And you can also find her on Instagram at Rebecca Patton _DPT. And, go ahead and shoot her a questionnaire and see if she's the right person for you. And she also has other information on there. So I want to thank you so much, Rebecca, for coming on the podcast today and sharing all your knowledge with the listeners. It's been a pleasure.
Thank you for having me. I really enjoy having these discussions, and I really am passionate to give everyone the care that they deserve. So any information that we can get out there about some of these like really difficult issues to talk about, I'm happy that people are listening.
Just fantastic. So thank you so much. I hope you enjoyed listening to this episode of Dr. Lottie, Science with Soul. To stay up to date on future episodes and to help us reach a larger audience, remember to subscribe, review, and share this podcast. If you're a person who understands the interconnectedness of mind, body, and soul, and would like to take one of my courses or work with me to create a path of healing your own life, please visit divinespiritualessence.com or drlottie.com. My book, Med School After Menopause, The Journey of My Soul, an inspirational story about transformation, healing, and spirituality, is available online at Amazon as well as other online platforms worldwide.